Ruth, do I pronounce it Ruth Iden? Is that right?
Isden.
Isden, Ruth Isden from Age UK, Morgan Vine from Independent Age, and Helen Wildboar and Judy Downey from the Relatives and Residents Association. So if we could just kick off by going around the panel, if you could just give us very briefly 1 or 2 sentences about what your organisation does and your role there. So Chris, can I kick off with you? Welcome.
Good morning, Munira. Thank you very much indeed. Good to see you again. So I'm Chris Hopson. I'm the Chief Executive of NHS Providers. We are the membership organisation for the 217 acute community mental health and ambulance trusts and foundation trusts. Our organisations spend about 80 billion of the NHS's £130 billion budget. They employ around 800,000 of its 1.2 million staff, and we have all 217 trusts in membership.
Great, thank you. Ruth.
Hi, I'm Ruth Isden. I'm the Head of Health and Social Care at the charity Age UK. So I oversee all of our health and social care work. Age UK is a federation of charities working at local, national and international level to support older people. And so we've been working throughout the pandemic, both nationally and on a local level, very much engaged with community-based support and what's been going on.
Brilliant. Morgan?
Yeah, hello everyone. I'm Morgan Vine. I'm the Head of Policy and Influencing at Independent Age. We're a national older people's charity. We have a national helpline. We provide information and advice on issues including things like care and money and benefits, health and mobility. And we also have a friendship service that we offer to people across the country, both through face-to-face and by telephone. And we've been supporting people throughout coronavirus on the key issues.
Great. And Helen and Judy. I can see Judy on my screen. Is Helen on the line as well?
She was there a minute ago.
Okay. Well, Judy, do you want to kick off?
Yes. Relatives and Residents Association is a membership organisation and represents the those people, older people needing care and in care. It has a daily helpline, and we provide advice, support, information. We provide publications and do work with care homes, hoping to improve the quality of the care, and our strapline is for quality of care for older people needing care.
Brilliant. Helen, sorry, I've just seen you on the screen. Is there anything you wanted to add? You want to introduce yourself?
Hi, yeah, no, Judy's covered it. I'm the director of the organisation.
Brilliant. Well, thank you again for joining us. I should have said at the start, so I'm one of the vice chairs of the all-party parliamentary group on coronavirus, hence why I'm chairing in Layla's absence. We've got a number of members from both the House of Commons and the House of Lords attending the meeting today. And I'll be kicking off with a couple of broad questions, but then we've got some, there are a number of themes and issues we want to cover that cut across your organisations. So a number of them will be aimed at all of you, some to individual organisations, but we'll let you know. So if we could just start with a really broad question around, for each of your organisations, for your members or your service users, what have been the main issues and challenges that they or you have encountered through this pandemic? Just, I know there have been lots, and there's a lot in your written evidence, but if you could maybe pull out, I'd say the top 2 or 3 maximum. Chris, shall we start with you again?
Thanks, Munira. So I think we'd probably see this so far as, in a sense, a game of 2 halves. So the first half was very much about creating the additional capacity that the NHS needed to ensure that we were in a position to treat what we thought would be or could be the same level of coronavirus patients that, for example, we'd seen in Northern Italy. So you will remember that, in a sense, the first half of the game was really ensuring that there was sufficient capacity. So 33,000 beds for coronavirus patients created, the new Nightingale hospitals, but also, which I'm sure we'll come on to, ensuring discharge of medically fit patients, but also ensuring that when you looked at all of that together, there was sufficient capacity. And just a couple of sort of things there. So, for example, oxygen system capacity, ventilator capacity to treat those patients. I think where we've now come on to is having sort of successfully surmounted that first peak of coronavirus demand. And I think the sense was that actually, certainly as far as hospitals were concerned, actually the level of patients they were required to treat with coronavirus was actually less than had been predicted. We're now in the phase of needing to fully restart services, but also catch up with the backlog that has inevitably built up as we've prioritized being ready for and then treating coronavirus patients. And clearly that is a big issue for the NHS, particularly when you recognize that in order to ensure effective infection control, you do have to, for example, in hospitals, create COVID only and COVID free zones. You have to ensure that, for example, people who are treating patients who might have COVID have got, full protective equipment. Just perhaps two more things very quickly, and then I shall shut up. So basically, I think we probably, I'm sure we will talk about the things that have proved problematic. I think if you asked our members what was difficult for them, inevitably, I think personal protective equipment would be one issue. I think a second issue would be testing, where, to be frank, there still are a difficult set of issues. Hope that's helpful. I think you're on mute, Munira.
Thank you. Sorry. If we can move to you, Ruth, next.
Sure thing. Thank you. Well, I think, as you expect, we've worked with a lot of the wider issues. This really has been a very significant crisis for older people. So we know, of course, that 9 out of 10 of the people who sadly died as a result of COVID have been over the age of 65. About 1 in 4, just a little over than that, were living with dementia at the time that it happened. More than 19,000 were living in a care home. So this really has been a crisis that's had a very profound impact on older people in terms of the rates of fatality, hospitalisation, and poor health and risk of infection. However, the impact for older people has gone much, much wider than that. So moving beyond that kind of very immediate risk, there's been a couple of things that have really been very difficult for older people. So particularly in the very immediate phase after lockdown, which of course disrupted everybody's usual routines and supporting mechanisms and coping mechanisms, older people were very, very much struggling with access to basic essential goods and services. So that was things like shopping, grocery, medications, and access to cash actually as well emerged as a very significant issue, because of course a lot of the support that was put in place, or a lot of the community groups that sprang up to try and offer support, it actually being able to access cash in order to ask somebody to go and do your shopping, for example, became a major barrier. So that's been something that older people have really struggled with, and we've come across many very distressing examples. Other things that have been particularly difficult during this period of time are some that you would expect, and some which are now just starting to emerge. So we've certainly seen some difficulties amongst older people who very much understood quite early on, as you'd absolutely expect given the messaging, that they were at particularly high risk from this virus. Of course, that was induced a great deal of anxiety and concern. However, it wasn't always very easy, certainly for us as an organisation and for others, to access really good quality, timely information, which older people were really, and their families were really desperate to have in order to be able to understand how to keep themselves safe, how to keep their loved ones safe, especially for those older people who were either advised to shield, and that was about 1.3 million people over the age of 65, or people who felt extremely vulnerable for one reason or another and weren't clear what they could do, and also what access to services might be safe. Following on from that, we've seen a lot of people who did withdraw from services or who found it very difficult to access health services, particularly, so ongoing routine or urgent healthcare services for non-COVID related health needs. And of course, this is a group for whom many were engaging with health services on a regular basis because of the nature of their conditions. But also, I think critically, we saw an awful lot of people who, particularly living in the community, withdrew from receiving care services, particularly domiciliary care services, because they were felt to be too risky for them to have people coming in and out of the home. So a lot of people have been going without care services during this period. And of course, alongside that, all of the community-based services and support, day centres, lunch clubs, exercise classes, all of those other things as well, were of course shut down for the duration of lockdown. And they're really struggling to start back up again for a whole myriad of reasons. This has had, of course, a very broad effect on older people's mental and physical health, some of which we're only just really starting to understand now, but we are starting to see a very important and significant evidence that the impact of lockdown, of ongoing social distancing measures, has led to a great deal of what we might say is deconditioning amongst older people. So people are reporting loss of mobility, increased risk of falls, loss of strength and balance, reporting low mood, and of course for people living with particularly dementia, in many cases that lack of stimulation over this period has led to significant levels of cognitive decline as well. So we really are starting to see that we're storing up a great deal of both mental and physical health need amongst the older population as a result of some of this. And then I just want to say one last word, I think, around carers. So obviously, the fact that so many people have withdrawn from services, the fact that so many services were unavailable to them over this period of time, and of course that increased level of need that I've described meant that the burden of support has fallen increasingly hard on family carers, many of whom are older people themselves. And we've certainly seen very significant evidence of carers, family carers taking up more and more of the support needs for their loved ones, and also more and more carers who are reporting feeling extremely close to burnout, and that they are really starting to struggle in managing that on their own. So I think that's probably a quick run around the major issues that we're seeing.
Thanks, Ruth. There's a huge amount there, and there are certainly a number of topics that you flagged that we were planning to ask some more detailed questions on. But Morgan, if I could come to you, if you could maybe flag the sort of 2 or 3 key issues that you'd like to highlight on behalf of your service users and people you support.
Yeah, absolutely. So I'd really echo what Ruth's just said. We're seeing the same issues coming into our helpline and from our teams on the ground. Just in addition to a few of those, so access to food has been one of the biggest problems that people have faced. And although there have been lots of improvements made, and we do genuinely feel like more people are now feeling confident about how they can access food, we also know that local authorities across the country have different levels of support that's being provided, and that a lot of people aren't aware of the options available to them. So that is still a concern, particularly if we hit a second peak. We would also talk about the changing guidance and how there's been lots of different guidance to follow. Sometimes changes to guidance have happened quite close together. So people in the shielding group have thought a change impacted them, but actually it was for the general public, but all the changes have been happening at similar times. And we've had lots of people get in touch with us who, for example, are in their early 70s, fit and healthy, and think they should be shielding and don't know if they're allowed to go and see a friend who's in a similar situation. So there's been a lot of confusion about the levels to which the healthy over 70s are what they're able to do during the pandemic, and obviously the knock-on impact of somebody shielding when they're not being advised to do that. Obviously it's their choice if they want to, but if they think that's what they're being told to do, that's obviously has a massive impact on mental health and anxiety. The other key thing that I think is something to think about going forward from our point of view is we did some calculations and we estimate that about 98,000 people have lost a partner during COVID, and that is 1.5 times as many as the last 5 years for this period. So there are going to be many people in later life who are experiencing complex grief, and I'm sure some of the panel will know what that is, but for those who don't, it's basically where you might have experienced multiple bereavements in one go. You didn't know they were coming. You couldn't be there with the person. You don't know if they had a good end of life. And all of that can combine to create a situation where people experience PTSD symptoms and would really need some professional support. So we're really concerned about the number of people going through grief at the moment and how they're going to be supported to deal with that. And on a related note, mental health support. So we're hearing from people who really confident, really fit, really able, who are now anxious about going into the town centre. They just don't know. They haven't been out for such a long time. And a lot of these people aren't shielders. They're just people who have been concerned about the virus and telling us that their anxiety levels are now really high. So we want to make sure that people of all ages, but also people in later life, get the mental health support that they need going forward.
Thanks, Morgan. And Helen and Judy, was there anything you'd like to add in terms of key challenges that we haven't touched on already?
Where do we begin? I'm going to start with a couple of major topics that we're concerned about, and Helen's going to do the third one, if that's okay. I think that there are some overarching things that we'd like to mention, and we would reinforce all that's already been said by the other people in terms of the impact on older people in the community in particular. We feel that from the beginning, there's been a lack of understanding about the care sector and its vulnerabilities at the top of government. I'd like to evidence statements made by the Secretary of State, the Chief Statistical Officer, the Chief Medical Officer, and the Chief Nursing Officer, all of whom seem to have an apparent lack of comprehension about the shape and structure of the care system, which made it increasingly difficult to manage and difficult to monitor. We noted the missing role of the regulator using its intelligence and reach sufficiently effectively, and an awareness that the social care sector essentially comprises a huge number of relatively small businesses. There are 3 times as many care homes. There are 3 times as many beds in care homes as in the entire NHS, and the size and complexity of the care sector really didn't seem to be taken into account in making policy. 500,000 beds for people in care homes, 4/5 of these occupied by older people. That's 18,000 providers in 39,000 different settings. 10,000 care homes for older people, mostly small and medium-sized, and a sector which has 1.62 million jobs reliant on a workforce that has massive vacancies and where huge numbers of people have acquired important and key skills, but basically reliant on people without professional qualifications. 51% of the workforce, according to NHS digital statistics, have no relevant qualifications. So we're talking about a very vulnerable sector and a very unbalanced sector in terms of being 80+% dominated by independent for-profit homes, 13% by not-for-profits, and a tiny percentage of local authority provision. So it's a very unbalanced market. And we feel that despite knowing and actually stating that older people and those with underlying health conditions are most at risk from the virus, the government made statements saying that people in care homes were assumed to be protected. Hard to know on what basis this judgment was made, but on the 2nd of April, the guidance said that tests are not required prior to admission or transfer to care homes. Even those testing positive could be admitted. And on the 15th of April, all patients discharged from hospitals would be tested for the virus, but by this date, 28,000 had been moved from care homes to hospitals. And by then, nearly 6,000 care home residents had died as a direct result. Only on the 14th of March were a handful of care home residents tested. And the pledge to test all staff who needed one, that was if they were in households who were self-isolating. By the 15th of April, just 1,000 out of 685,000 care home staff were tested. So, and Helen's going to talk about the failure of planning.
Yeah, so hopefully everybody can hear me. I've just unmuted myself. I'm going to focus on the lockdown of care homes and the impact that had on older people. So many care homes closed their doors to visitors long before the government called for a lockdown. Many care homes locked down in February, so now that's many months for those care homes that did in February. And the government guidance then advised care homes to stop visits except for in exceptional circumstances like in end of life. There was no risk assessment for the sudden ending of visits and cutting off those vital support networks for older people receiving care. And that, just to pick up on what Judy said, that demonstrates a lack of understanding about the role that many relatives play as a central part of the care team for their relative, helping not only with emotional needs and providing emotional support, but also providing really crucial practical support to their relatives, such as help with eating, drinking, etc. And many people in care homes faced a double isolation. So the isolation from external contacts as visits were stopped, no longer able to receive that support from friends and family who would normally visit regularly, but also the isolation internally from care homes restricting movement, people being asked to stay in their rooms, those shared areas would be closed, lack of activities. So then people living in care homes were not getting the support from and the interactions they would normally get with other residents and with many staff members. For those with mental capacity issues like dementia, that isolation would have a much more detrimental impact, particularly if the person can't understand why those changes have suddenly been brought into place and why their family is suddenly no longer visiting them, and with fears of what's happened to their family, whether they're safe, or why they're no longer coming, which has caused lots of distress. And people go into care not only to have their care needs met, those physical care needs, but also their social needs. And if you take away that social element, the social support networks that people have, homes become very different places. And sadly, many of the callers to our helpline have been telling us that the current situation in care homes is now very much like a prison, with the such restricted visiting, residents unable to leave the grounds of the home, and those limited interactions with other residents and staff. And this has had a really devastating impact on mental health, not only for people using care services, but also for the staff who have been through some very challenging times over the past 6 months, dealing with that isolation and the loneliness that comes with that, and the mental health issues that come with that, not only for the residents, but also for themselves. The increased distress of the residents, the bereavements that we've seen, whether they've had the training on how to deal with that and the support that they need to deal with that. And we know that many care staff are now sadly facing burnout. And we hear daily from our helpline callers about how their relatives in care are deteriorating, not just their mental health, but also the knock-on impact on their physical health of older people losing weight, losing speech, losing their memory, no longer being able to recognise their family members. And as one relative put it to us, they're losing the will to live. So we really need to find a safe way to manage the virus going forwards in care settings, to achieve a better balance between protecting life and protecting well-being. And there's a really good quote from Justice Mumby, who said in a case where he was considering that balance between physical safety and emotional well-being, he said, what good is it making someone safer if it merely makes them miserable?
Thank you, Helen. Some really big issues you flagged there, which we are going to delve into further. But before we go into some of those more detailed themes, Caroline, could I bring you in here for your question? Is Caroline still with us? I know she was having some connectivity problems.
I'm so sorry, can you hear me?
I can hear you now.
Thank you so much. And I do apologise, I've just turned my video off just because I'm in the wilds of Wales where Wi-Fi is problematic, so I do apologise for that. But I did have a general question I was hoping to ask all of our witnesses, perhaps in the same order that they've just spoken, if that's all right. Many of you have identified problems that in a sense aren't new to us, knowing about the problems around testing and PPE and around the complexity of care homes and so forth. Obviously, the government has known about that for some time. And the question really is, what did the government do when problems were brought to their attention for the first time from yourselves. I wonder if you could give us an insight into what was done to overcome the problems that you've identified, and in particular what support was provided by government.
Hopefully you all caught that. It was slightly broken up, but broadly it was around what support you've had from government. And if you could try and be reasonably succinct, because we've got lots of rich issues that we really want to dig into in more detail. So Chris, could you maybe kick us off?
Well, it's very difficult to give a detailed answer to that, a question like that. But here's our sense. Our sense is that this was a virus that hit the UK and it hit the world relatively short notice. And my personal view, and I said this on the media about 2 or 3 months ago, is that I think we should assess the government by its ability to perhaps not necessarily get the first reaction right, but actually to listen very carefully and adapt to the feedback that is coming back from those who are at the front line. So if I give you a couple of examples, we certainly felt that in terms of PPE, we very quickly flagged that there was a problem, and we then did a very concerted piece of work working with the government and working with NHS England in improvement that certainly for our sector, and I accept it absolutely wasn't the case for the social care sector, the primary care sector, and for example, the hospice sector, but for our sector, partly because of the logistics involved, there's only 217 trusts, actually we felt that the government did respond pretty and NHS England responded pretty rapidly to the feedback that we were giving them. I think on testing, our sense would be we were flagging problems really, fairly early on. I think our view would be that it did seem to take the government an awfully long time to set up NHS Test and Trace, which I think is beginning to get there, though it's still got a number of different problems. So I suppose my answer would be that on certain problems, I think particularly where actually the government was able to mobilise quickly, then actually I think there was a response, but in others it took quite a long time. But I think one of the themes that will come out of here, out of the session today, is that I think the NHS experience has probably been really very different from the social care experience. And I hear very loudly what Judy was saying, which is that the social care sector, which we don't represent, went into this pandemic in a very, very different position to the NHS. And I completely accept the argument that I think most people now argue that the government perhaps did not do as much as it should have done at the speed which it should have done in relation to the social care sector. But in terms of what we experienced, it was differential depending upon the issue.
So before we move on to Ruth, actually, I just wanted to bring in Lord Strasburger here, because I think he wanted to ask a follow-up on the point you've just made.
Thank you, Chair. I wonder what's the view of the witnesses on the view that the protection of the NHS was mistakenly prioritised over saving lives?
Well, I think our response, Lord Strasburger, would be that effectively the NHS did what it needed to do in order to ensure that it looked after the patients for which it was responsible. I think we would, and again, it's not my area, but I recognise, as I've just said, the idea that actually I don't think the government did what it should have done in relation to social care. The bit that I have a problem with, if you don't mind me saying, is the idea that effectively social care wasn't prioritised because the NHS was prioritised at the expense of social care. I don't think that's the right formulation. I think the right formulation for when we sit is that the NHS did what it needed to do, but the social care didn't do what it was needed to do. But I think the concept that was because it was the NHS was prioritised at the expense of social care feels to me to be making a comparison between the two, which really, from where we sit, isn't particularly helpful.
I'd be interested in the views of the other witnesses on that.
Thanks, Chris. If we move on to Ruth about support from government and the question that Lord Strasburger asked.
Well, I think I'll just pick up off that question there. I mean, in my view, it's both and. It was important to ensure that the NHS had the capacity that it needed, in order to address the challenge that we all feared it would face. And of course, now we're in a position whereby that, you know, we're now in a position where we need to support the NHS to move forward, to be able to have the capability and the capacity to do both, so it can get back on track in terms of that routine and ongoing and urgent healthcare relating to non-COVID related support, as well as ensure that it has the capacity to meet whatever challenges this winter has to throw at us. So I think so my answer to that is and both. But I think I would certainly reflect Chris's views that the social care system did not go into this in a position in which it needed to be. So, I mean, we can talk at length about the deficiency, the long-term historic deficiencies of the social care sector and the failure to reform the social care sector over a very extended period of time. But we know, for the purposes of this conversation, the social care sector was in a very weak position entering into this pandemic. Then, of course, the crisis hit, and I think one of the reasons it was in a weak position, and one of the things that I think as a byproduct of that was actually there was a lack of understanding and a lack of insight and a lack of knowledge, which, of course, Helen and Judy have already spoken about at national level, about what the realities on the ground would look like for the social care system, actually what kind of capacity, what the realistic capacity was of the system to respond and to weather this storm. And I think that also reflects as well, and I'm just sort of speaking a bit more broadly to some of those wider issues that I referenced in my earlier remarks, is I think that also reflects a lack of understanding perhaps about older people, about aging, and about, you know, the way that this overall crisis would impact on older people living in the community as well. So I think there was a slowness to respond. I don't think we responded as quickly as we needed to the crisis. We didn't recognise it or it wasn't recognised quickly enough at government levels. I certainly, those of us working in our sector were raising these issues because of the over weakness of the sector. But then that weakness, in effect, meant that it's partly the case that there was just that lack of understanding, and those two things probably sit together. If there'd been a greater depth of understanding, we'd have probably been in a stronger position going into this in terms of where the sector was. So I think those are kind of related issues.
Thanks, Ruth. Morgan, was there anything you'd like to add from government support and this suggestion that NHS was prioritised over social care?
Yeah, so just to start with the NHS social care issue, I mean, for most people, particularly those in later life, they're relying on both those systems, and it's no good one working brilliantly and then they go back into their own home and need a domiciliary care package and nothing comes, because they'll end up back in hospital. So I agree that the NHS, of course, should have been given the funding it needed to manage this crisis. But we were really concerned when we saw the Care Act easements in the coronavirus bill, now the Act, and we couldn't really understand why so much support was being given, rightly so, to the NHS, and at the same time it was being pulled back from the social care system, which was already not in a great state when we started this crisis. So that's one thing I'd say on that. In terms of Caroline's question about how the government responded, I just want to raise two things which might be slightly different to others, so I thought that might be helpful. When it comes to access to food, as I mentioned, at the beginning of the pandemic, we surveyed a couple of thousand people and 50% almost were saying they were struggling to get food. They couldn't get supermarket slots, they were skipping meals, reducing how much food they were eating, or relying on others to get their shopping. We've had a really good experience with DEFRA, and they have made some really good positive changes based on stakeholder feedback. So, for example, support to access food is no longer restricted just to the shielding group. It was widened out. They also gave more support to carers who weren't originally in that pool. So now if you're a carer and you don't feel you can leave your house to go to the supermarket for whatever reason, you should be able to access support. The thing that we want to ensure for the next stage of this is that every local council across the country is supported to offer the same options to people, so that regardless of where I live, I can know that I'm entitled to the same support. I think that's something that's really important. The other thing that we liaised quite closely with government and lots of other stakeholders on was around the guidance and the clarity. And I think one thing from Independent Age's perspective is that we believe that guidance could have done with a bit of clarity, and that could have come quite early on. So, for example, the clinically vulnerable group, which was the second tier down under the shielders, were told to take particular care, but there was no sort of fleshing out of what that meant. Did it mean wash your hands more regularly? Did it mean stay further apart or be in groups of less people? And I think bearing in mind that whatever you think about the decision, everyone over 70 was told that they were automatically in that group. We think some clarity would have been really great earlier on so that people could make their decision about what they felt the risk was and how they wanted to conduct themselves during that period.
Thanks, Morgan. Judy and Helen, was there anything you wanted to add from your perspective on these questions?
Yeah, I think it's hard to be positive when you're asked about what the government support was in this context to care, because as I think it was Morgan said very clearly, the guidance was confused and contradictory and often too late. And that was really very hard for people to cope with. I mean, care home managers, faced with sort of 60 different bits of guidance from different sources, some contradicting each other. And Helen will say a bit more about that. But the other thing that I'd like to mention, although it's kind of putting the question upside down about the support for government, the fact that government support was actually withdrawn. We have a very vulnerable sector. We've all gone on about that ad nauseam. A lot of huge turnover, massive vacancies, large numbers of people without qualification working their socks off, poor pay, lousy conditions, not getting paid if they don't work. We all know about all of that, but that didn't seem to be factored into any of the support. And also the fact that CQC, which is the organisation set up to protect vulnerable people in registered settings, decided that it was switching off. And, they said they didn't want to spread infection. Well, if the government agency can't get PPE and tested, we despair. Helen, you want to add a bit more about the advice as well that came?
Yeah, so just in terms of the kind of what was done to overcome the problems by government, in terms of visiting and lockdown of care homes, the government guidance on stopping those visits provided very little support on alternatives other than, using telephone and video, which is completely impractical and simply not an option for some people in care. It didn't provide any support on how to maintain well-being during that lockdown. The government guidance on visiting was then withdrawn on the 19th of June, and we were told it was being replaced with something. We waited over a month for that replacement, with care homes and their residents in limbo during that time. When it was finally published on the 22nd of July, that new guidance, it lacks clarity, it lacks leadership, it's difficult to follow. And for many care homes, it actually takes them backwards rather than forwards in terms of lockdown and visiting. And particularly disturbing for many of our helpline callers has been the part of the guidance which says that a care home resident should have one single constant visitor, which is just impractical for many people and heartbreaking for many families who may have 2, 3 more people who want to visit them and provide different types of support. As I said, people are providing emotional support as well as really practical support. And in terms of the disparity between health and care that's been mentioned, the Scottish guidance was very different on this, and so was the guidance on visiting in hospitals. That guidance for the NHS was permitted visits for people with mental health issues like dementia, where not allowing a visitor would have been too distressing for that person in hospital. So there's been a disparity between the guidance between hospitals and care homes, and as Judy said, contradictory guidance in different settings and from different agencies.
Thank you. I wanted to bring in Barbara Keeley next, if I may, to pick up on some of those themes you've just touched on.
Thank you. Yes, I've got questions on care homes, but also questions on shielding. But we'll start with care homes because you've just been talking us through that, Helen. I mean, Helen, you said earlier that lockdown had led to care homes being like a prison, and you've also just stated a lot of further issues in terms of the guidance and lack of clarity, and some care homes going backwards. Could you expand on that for us? Is that widespread? I mean, the what you said about care homes being really like a prison for people, and you know, to your knowledge, is it being done better in some places? Are some places examples that should be followed? Because you know, if government guidance is wrong, clearly something needs to change.
So yeah, those are the reflections. This is what we've been hearing through the helpline that we run. Lots of the callers to our helpline have been incredibly distressed over these past 6 to 8 months about the lockdown and about the impact that's having on those people receiving that care. There's also a knock-on impact on the mental well-being of those relatives who are on the other side of the door, and the anxiety that they've had, sort of not knowing whether their care home that their relative is in has COVID, what the COVID status of that home is, and the anxiety of, you know, if you do have calls over video, watching and seeing your relative slowly deteriorate over weeks and months, and they can see how much weight the person's losing. They can see how much their mental health is deteriorating, and that's heartbreaking for the relatives as well as for the people actually living in care settings. So in terms of what we've been hearing on our helpline, a lot of people have been saying that to us, that they feel it's akin to a prison. In terms of you know, what could be done different? I mean, as I said, the guidance in Scotland was very different on this, and the guidance for NHS visits, and that just shows that lack of the disparity between health and care settings, that a person can go into hospital. We heard from somebody today whose, I think it was father has broken their hip and got into hospital, and they've been able to go in daily to visit him while he's in hospital. Once he goes back into care, those restrictive visits will come back into play. He'll be self-isolating and asked to stay in his room for 14 days because he's been out of the care home and then coming back in. And then they will go back to the visits, time-restricted visits for a single constant visitor. So the disparity we're feeling, a lot of the unfairness is coming through on our helpline about the different settings, and people becoming very frustrated that has not been rectified in the government guidance that's been published.
Can I add something about good practice that Barbara asked? We certainly are aware of some superb practice, Barbara. I mean, you know, heartwarming practice with very good providers making enormous efforts to have weekly newsletters to families, phoning them up weekly, letting them know how their relative is getting on, not only issuing weekly newsletters, but actually explaining the status of the home. Because I think we have to remember that 60% of homes didn't have COVID, but some of those have been shut down too. Mm-hmm. And, you know, it's very difficult as I said, it's such a disparate sector and so many small providers, and the guidance being so confusing. I mean, I think for a lot of people, to get back to Lord Strasbourg's question, thinking they must protect life at all costs without actually valuing what makes life worth living, as Helen said. I mean, Justice Mumby's very, important words about, what makes life worth living for most people. It's interaction with the people they love and doing things they like, and all of that is gone. And it's not necessarily because there's COVID present. And sometimes there was, and sometimes there might be, but it's people living in a kind of hideous limbo. And some people, as Helen says, saying to us that, their relative would rather die than carry on living like this.
Yeah.
You know, we have to balance it. And to talk vaguely about risk assessments when there isn't proper advice about decent infection control, the use of pharmaceuticals, any proper oversight. You know, we talked about psychological damage and physical, people going back physically, but the kind of infection control that most homes have dealt with in the past is of a different, it's of a different level, it's a different complexity from the kind of amazing difficulties caused by COVID. So, you know, to talk about risk assessment and expertise when people are struggling just to staff the place, and then not even having guidance about the use of agency workers to restrict their use. I mean, there was something on the BBC channel today about a care worker heartbroken because she has found out just that she has COVID, and she's been working in 4 different care homes. And she thinks she also contributed to her own mother's death because her mother was 82. She visited her not knowing that she was herself was COVID positive, and her mother has since died. I mean, to talk as though, and I absolutely understand why the NHS is important, but the NHS was actually set up for older people, and they've been the victims often of the failure to prioritise them. And, you know, why haven't they had decent PPE? They still haven't got it, and they're still not being tested. The government announced 50,000 tests a day. There are, you know, the whole social care sector comprises nearly 2 million people. We're counting all the people that work in the different domiciliary and residential settings. Each of those needs to be properly protected and not feel they ought to go to work because otherwise their families aren't going to eat.
Yeah,
We're sometimes putting infection into care homes. We don't know what conditions a lot of care workers are living in.
Yeah.
We can't put all the responsibility on them without even paying them for when they're off sick.
No, I think that was a very good point. So we take that there are real challenges for staff dealing with the isolation and illness and the decline that Helen has talked about. I just don't know if you've got anything you wanted to expand on for the committee on that. On those challenges, because as Judy pointed out in the start of her evidence today, it's a sector that already had a very high vacancy rate, easily 122,000, and more than half the staff, as you said, Judy, don't have a qualification. So I don't know what your thoughts are, or the thoughts of your of the people you represent in terms of that going forward, and what should be done best now.
Yeah, so when people call our helpline, as I say, they're calling about concerns about the person who's actually, you know, receiving care. They're also concerned about the staff who seem to be working incredibly hard under very difficult circumstances without the kinds of support that you would expect with having PPE and having testing, sort of the basic tools that we would expect to be available to frontline staff to be able to make sure that they can deliver a safe and dignified service, to keep the people that they're caring for safe, but also to keep themselves safe and their own families safe. And you know, here we are sort of 8 months down the line since the virus first came to this country, and we're still talking about a lack of those very basic tools. And I think that's incredibly frustrating for staff, and we know that there are staff who have lost their lives and paid the ultimate price for that, but it's also incredibly frustrating for the people that they're caring for and their families, who are very worried about the virus spreading within care settings. And
could I just ask you what sense you have about how widespread that is? Because we are concerned as a committee about as a group about the PPE problem. I mean, do you feel it's just as bad? Because, you know, certainly I've been in contact throughout with care homes in my constituency, and I think there was an improvement, and that, you know, that there was a sort of step change at one point. But you're hearing, could you tell us what you're hearing about how it is now?
So,
because,
I mean,
no, we've got to face a second wave, haven't we? So we need to learn the lessons from the first.
So yes, lack of PPE has been a major concern on our helpline since the outset.
And still is.
Of the virus, and still is. So when relatives are on video calls or they're doing outdoor or window visits to their relatives in care, they can see the staff sort of in the background, or some of those visits are monitored by staff. And we're still receiving calls from people who can see staff either without PPE or wearing it incorrectly.
Or using it again and again.
And we don't know, you know, the quality of that PPE. And it, you know, we've seen some of our helpline callers have been so desperate to get a safe visit with their relative in care, or to ensure that the care home that their relative is in is a safe environment, that they, you know, we had one caller who spent their own money to provide PPE for a care home, which the care home couldn't accept. And you know, the supply problems have been well documented, and we continue to receive calls about that, and we hear from providers that there is still limited publicly available, publicly funded supplies of PPE, and some care providers are actually passing the costs of that PPE onto residents of care homes. And we've been receiving calls from people who have faced either increased fees for their care, or extra sort of COVID charges that have been added on to their weekly or monthly charges. And we've been calling on the government to provide free PPE for not only for staff but also for care users and for visitors across the whole of the care sector, not just in care homes but for domiciliary care and people in supported living, where, you know, in other care settings where that's needed as well. And that should be a basic principle of infection control, that is centrally provided and paid for.
Okay, thank you.
Barbara, I know you wanted to move on to shielding. Before you do, I know Dan Poulter wanted to ask some follow-ups on PPE while we're on that topic. We'll come back to anything if we could.
Yeah.
Thank you, Munira, and thank you to our guests for the evidence they've given so far. One thing that struck me when Chris Hobson outlined was that he felt that on the NHS side, that NHS England were very responsive to concerns that he raised from an NHS perspective on behalf of providers about availability of PPE, but sort of to paraphrase, I suppose, that felt that on the social care, from social care, there was a government that was perhaps to some extent asleep at the wheel in understanding or responding to the needs of the sector. I just wondered, the one thing that occurred to me was that social care is commissioned by local authorities, and I just wondered, you know, what role, if any, the panelists felt that local authorities played or could have played in, they also have, of course, a public health function in providing support and advice to the care sector, in particularly in regards to sort of PPE and testing.
So Dan, can I just, for me, I mean, we spent a lot of time in the first half of the first wave talking to our colleagues at NHS England about PPE distribution problems. And I think the bit that, just to be fair, that we need to be really clear about is that there is this division between 217 trusts and foundation trusts and 55,000 social care providers with the kind of diversity that Julie's described, but also primary care, hospices, etc. And what happened is, as you know how this is meant to work, which is there is a national stockpile that effectively you can access and hides you through until the materials that you start ordering when the crisis hits then kind of come on stream, and that will take however long it takes, 2 or 3 months. So what happened was that when demand for PPE went through the roof, actually what happened was the strategic stockpile found it relatively easy to deliver to 217 trust and foundation trusts, because they moved straight away to a push system whereby effectively they were pulling pallets of PPE out of the strategic warehouses, and then were effectively sending them on a push basis to 217 trusts and foundation trusts, fully confident in the knowledge that if they sent them masses of boxes of masks, masses of boxes of gloves, masses of boxes of aprons, they would be used. And of course, the key about 217 trusts and foundation trusts is only 217 of them. And also we've got distribution facilities and goods in facilities. That means that we can take deliveries at 2 o'clock in the morning, which was what was quite often happening. We were being rung up, our members were being rung up at 11 o'clock at night and being told, it's arriving in 3 hours, make sure there's somebody there. There's then the contrast with the 55,000, where effectively you can't just send pallets and boxes of materials. You actually have to probably pick 20 gloves or 50 gloves, 100 masks, 35 aprons, put them into a specific package. Part of the problem was that the 55,000 are actually not customers of supply chain. So our 217 trusts and foundation trusts, the delivery details were simply handed to the strategic reserve, and they had them all on the computer straight away. But the problem is that the vast majority of the 55,000 had never come in contact with either supply chain or with the strategic reserve. So they had to go through a process of getting a call in, logging the details of where the material needed to be sent. As I said, picking relatively small numbers as opposed to just, you know, proactively passing pallets to our members. And then effectively, they then had to ensure distribution, again, to places that, to be frank, were not open 24 hours a day. So the two logistical challenges are completely different. And so when we were talking to NHS England, what they said is, look, it's relatively easy for us to sort out you guys. The big problem that we've got is the 55,000. And I think NHS England, again, it's not my job to speak for them. You know, I'm an independent membership organisation. But to be fair, they had a massive logistical challenge to set up that distribution system for the 55,000. Because again, as you've already heard, when those 55,000 were going to their normal wholesalers and retailers, what they were being told was, no, we've run out, global shortage. So I buy the argument about the need for that, just, you know, for the government to, in a sense, get its act together and to ensure that distribution works effectively. But I can absolutely see why it was easier to solve for our 217 trusts, given the number of them and the volume of kit that they needed, versus the diversity of the 55,000, where you've got much, much smaller volumes. That hopefully is a helpful perspective.
It is very much. I mean, I think that's absolutely very, very helpful, Chris. And just onto that. I mean, you know, as I mentioned in my opening in my question, was that the commissioning of social care is done by local authorities, not by the NHS, which of course compounds some of the challenges that you have outlined when you've got such a wide number of providers. But I just wondered, and what I was trying to get to with my question is, how effective was the engagement with local authorities by central government in addressing this issue of providing PPE and testing for the care home sector, and how much of a role should local authorities have, given the fact they also have an important public health function in actually taking a leadership in this and in the early stages of the virus?
Well, I think what happened, Dan, actually is over time, what I think people realised was that the local resilience forums were the very obvious place to use to provide support. So what happened was our members who because they work so closely with, for example, care homes, were hearing very quickly that there were problems. What they were immediately doing was either supplying direct to care homes where they had spare stock, or alternatively working with the local resilience forums, which, as you know, are effectively local authorities meet, the NHS meets key, emergency services in an area, and they rapidly developed into the places where effectively, if you needed emergency supplies, you went to the local resilience forum. But your basic point, I think, is a really important one, which is that one of the questions we're going to need to answer here is a single national strategic reserve distribution system the best way of effectively dealing with that diversity of supply? And I think there's a pretty clear answer that actually a better approach would be to actually have a series of lower tier, probably regional stockpiles where effectively, if needed, that's the place where you go. For us, 217, I think the national level works, but I think for the 55,000, I think it doesn't. And that's what I think we learned through this process, is that actually, and again, this is just one of several, testing is a great example of where actually the government reflexively reached for centralized solutions, but it realized relatively quickly that what it actually needed to do was decentralize more power lower down. And that's exactly the process I think we're literally going through with testing. And I would argue it was the sort of process we began to go through with PPE. But we need to answer that question about where does the stockpile effectively sit for the 55,000 going forward.
Manera, you're muted.
Sorry, Baroness Fidley, can I move to you, please, just to pick up on that PPE point, and then a couple of other questions.
Yes, thank you so much. I mean, just to pin you down, Chris, really, and I guess before I start, I should declare an interest. I've got two interests. One is that I chair the National Mental Capacity Forum. So all impairments of mental capacity have been a responsibility. And secondly, that I've been very involved in the Distance Aware initiative because of those who have been shielding or shielding somebody else, feeling that it's becoming less safe as they come out from lockdown. But if I can pin you down, Chris, you've described the problems. Do you think the lessons have been learnt, and that when we go into a second wave, things will be better organised? Or do you think they're still at the stage of these are what should be done, but nobody's implementing them?
I thought Helen was very interesting in the answer that she gave, where I was listening really carefully. What I thought I heard Helen say was that effectively the distribution problems seem to have got better. And certainly the intention was the government was going to set up a direct ordering system for the 55,000, an Amazon style kind of website where you could effectively get registered as one of the 55,000, and then you'd be able to order PPE from that central site and it would come to you. I think what Helen pointed to, which absolutely our members reinforce, is that because of the nature of the social care sector, sometimes actually the staff usage of PPE and the quality of the infection control inside local care homes is perhaps not what it should be. So even if perfect amounts of stock going to those homes, actually what they need is help in using them properly. And that's what our members, quite a few of them, have said to us. They have been trying to help care homes because obviously they have infection control teams for whom it's literally their day job is to make sure this works effectively. And they've been working.
I'm going to shorten you a bit, Chris, if I may, because I'm really worried about the time. And I did want to ask a much broader question, which is whether people think that the elderly and those who are vulnerable have had delayed access to care and were unable to access the care that they needed because of blanket policies being in place, which seem to exclude them from transfer back into the NHS, transfer within the NHS into ICU on basis of age or comorbidities, and whether some of those blanket policies that were designed to stop us having people lying in corridors, such as we saw from the Italian pictures, whether actually those worked against people, and whether people have understood that DNA-R is not legal, it is dangerous, and we are only talking about DNA CPR as a clinical decision on an individual, but that any of these blanket policies should not be there. And I think I'd like to go to some of the broader group, if I may, who've given us evidence, but particularly perhaps Helen and Judy to start with.
Well, we certainly know that DNA-R is still in operation in lots of places. Certainly, I don't know how common it is, but lots of people that I know living near me, and I'm well over 70, in fact I'm over 80, have had letters suggesting that we might let our GPs have information about our wishes, and I'm not in a care home. So I think that the pressures on medical staff throughout has been, let's be careful that we don't extend life unnecessarily, rather than how can we please preserve life to ensure that it's a decent quality and that people survive regardless of disability or mental incapacity, to have good a life as they can. I'm delighted to hear that things seem to be better in some aspects of PPE, but we know that people are still not getting it, and people are certainly still not getting tested. And we've heard of care home providers driving all over the country for supplies, trying to get supplies from China. And there's been really an unseemly battle between providers, sometimes trying to do the same job to get the basic tools of their trade. And that has not improved enough. That is certainly not good enough. And people seem to not be aware that you don't get one set of PPE for life. They need to be changed for each individual person with an infection. So there's a sort of, talking about the numbers or talking about the numbers of tests, none of this is once for all. It's a repetitive enterprise.
Oh, I wanted to get a little bit away actually from some of the PPE issues, and I wonder if we might go to Helen, because I think that I'm not talking about approaches that try to what their wishes are and how they would like to live, because one wants everybody to be able to express their wishes if they can, and their family on their behalf. What I was concerned about was whether there were blanket policies that were stopping people getting the care when actually they wanted the care, and their families in particular, and they probably also felt that they should have been eligible for a higher level of care, or that the care was not able to go into the care home because those more expert clinicians were actually being excluded.
So yeah, there's quite a lot to unpick there. I think certainly towards the beginning of the outbreak, when we saw those messages around the clear message from governments around protecting the NHS, and a move to try and sort of free up beds within the NHS to try to ensure that the NHS was prepared for the outbreak and wouldn't become overwhelmed. I think that led to some policies which clearly have had a detrimental impact on older people, and particularly those in care settings, as Judy has alluded to in terms of the discharge from hospital. But we also saw it the other way, and people who live in care settings, we had calls to our helpline from relatives who were really concerned that the resident wouldn't be transferred to hospital for care, that could be, as you say, part of a person's wishes. If a person has decided for themselves that they want to spend the rest of their time in that care setting and move towards palliative care, that's for them, and that should be respected. But where it's really concerning is where that isn't happening, and where the person isn't being consulted, or their family isn't being consulted about where they would want to go to hospital to get that level of treatment.
Could I ask Ruth to come in, because I think you had some really strong evidence that came through from Age UK.
So, as Helen said, I think there's a lot to unpack here, and I'd offer a few reflections. I think the first thing to say is, again, it goes back to we wouldn't start from here point about the overall kind of position of the care sector, and specifically with regard to this, I'd say, it was recognised in the 5-year forward view about 5 years ago that the care home sector was desperately underserved in terms of access to clinical support, and what we needed to do was to wrap clinical support around care homes and care home residents in a much more strategic way. And of course that has been, and then the NHS long-term plan is the intention to roll that out nationwide after a series of successful pilots. Of course, that the enhanced care in care homes has been massively accelerated going into this winter, but would we have been in a much better position to safeguard the health of care residents during this period of time, if all care homes had already had access to the enhanced care and care programs and that wraparound multidisciplinary clinical support, then the answer is yes. Yes, we would have been. So I think that's the first thing to say. We were starting from a low base where actually still there was parts of the country and care homes who still lacked that basic kind of ongoing routine and enhanced clinical care. Of course, so I would start by saying that I think even we have seen some very distressing examples of blanket policies applied to care home residents and also to people perhaps living in their own homes as well in some instances. And our view is those are always completely unacceptable. And I think, again, to be fair, once it started to become apparent that these protocols were being applied at local level, then NHS England and the government were quite quick to say, to echo that view and to give a very strong signal to the system that no, blanket application of policies, whether that be DNA, CPR, or whether that is criteria around admission to hospital, everything had to be done on a case-by-case basis, which is absolutely the right approach. But I think, again, what part of that reveals to us is the fact that there is not fantastic understanding necessarily across all parts of the NHS about clinical care of older people.
Yes.
We have seen this in many contexts over the years about people conflating issues around age and frailty and comorbidity and not necessarily having the expertise in order to make some of those actually quite refined judgments. Yes. And again, I think this is something that we saw come to the fore, really, that you had often people who didn't necessarily have the right clinical expertise around care of older people being asked to make judgments and decisions. Yes. about that community and maybe applying kind of blanket criteria or applying a blunt instrument, which was a view about their age in that context.
Yeah. Could I bring Morgan in now? Thank you so much, Ruth. And I think also really thinking about delayed access to care now for people who have comorbidities and whether we've got anything better as we go forwards. Morgan.
Yeah, so we chatted to our colleagues on the helpline just last week to ask them if we were still getting calls about this, because as you can all imagine, it was something we were hearing about, but we wanted to check it was still a problem. And they fed back that despite the fact that no current local authorities say they're enacting easements, Care Act easements, people are still calling us about packages being suspended or cancelled. There's an increase in informal carers having to take on the provision of care and support. People are delaying seeking assessments because they're really worried about infection control. And we've heard that throughout the pandemic. We've heard of local authorities not reviewing care packages because they've said they can't come and assess face to face. So people are just waiting with severe care needs for an assessment. And they've also talked about waiting times being longer than normal. Also, just to come in on the health side to back up what Ruth said, we were really concerned at the beginning of the pandemic when this draft intensive care decision support tool was leaked to the press. And it had a weighting for age on its own, regardless of frailty, regardless of underlying health conditions. And it gave you something like 7 points. And if you got 8 points in total, you wouldn't be able to access intensive care treatment. And we felt that was essentially an ageist policy. Frailty, we understand, fitness to treat is obviously really, really important. But we didn't see that somebody's age should almost be double counted against them when it comes to intensive care. And I think moving forward, we would really want to make sure that any tool like that, if it was brought in, and it wasn't on this occasion because the NHS was able to cope with what was happening, but if any tool like that was brought in, that it was fairly weighted and wasn't disadvantaging people in later life.
Thank you. I was going to move to Paul, to Lord Strasburger now, please, if we could.
Thank you, Chair. On the subject of staffing, what impact did the use of agency staff, do you believe, have on infections in the care sector? And also, what mitigations do you think are needed for the disproportionate impact suffered by BAME staff?
Who would like to pick that up first?
Shall I start?
Okay, Judy, if you kick off.
We know that unlike other countries and other advice, there was no guidance about the use of agency staff. In the province of British Columbia in Canada, and there are other examples, I think in New York also, agency staff were forbidden for working in more than one place. And it should have been possible for there to be government guidance, and there should be in the future, of restricting agency workers to particular groups and making sure, of course, that they had appropriate protection and testing before they went from place to place. But we know the problems of being asymptomatic, but that's the very minimum that people should be doing. We know from research that's come out recently that agency staff had a disproportionate effect on spreading the virus. We also know from evidence that Unison has published that care staff were very torn between going to work with symptoms and not working, and that meant not earning anything. So, you know, it's a very complex problem, but it is possible for there to be better guidance to ensure better use of staff and better protection for staff. And certainly, as I think both Ruth and Morgan have said, the importance of good infection control. And, you know, if we can have 24-hour helplines for this, that, and the other, it seems really important when people know how isolated care homes are and how often lacking in professional expertise some of the staff and managers might be on pharmaceutical problems, on for example, one of the rigidities in care homes at the moment is that they're not allowed to carry a stock of anticipatory medicine. So if there's been a particular person perhaps with problems with acute anxiety, or with they can't stock that particular drug to use for someone else without having medical oversight, and they're not getting medical oversight often. They're not allowed to reallocate medication that was prescribed for someone else, which hasn't been used, for another patient without a very complex bureaucratic procedure. So there are all sorts of inhibitors which assume there's going to be oversight, which actually, in fact, didn't exist and still doesn't.
Was there anybody else who wanted to pick up on the point about turnover of staff and agency staff, and particularly BAME impacts? I know, Chris, if I can come to you briefly first, and then I'll come to you, Morgan and Ruth.
So, Munira, I just wanted to just double check, are we going to cover NHS discharges into care homes in a later?
Yes, we're coming to testing shortly, and I wanted to pick that up there. Okay, so
BAME staff, then clearly one of the things that I think we discovered very quickly once the virus started spreading was that it had a disproportionate impact on BAME communities. My kind of sense is we were probably collectively as a health and care system slower than was ideal to pick that up. I think what's happened since then in terms of the NHS sector is we have been doing as rapid a set of work as possible to try to identify how we can manage that risk, both with patients and staff. And I think, as you probably know, certainly in terms of staff, our trusts have just nearly almost completely finished now a set of risk assessments where effectively they've been risk assessing each individual BAME member of staff and ensuring that any personal risk to them is appropriately managed.
Okay, thanks. Morgan and Ruth, if we can come to you about the use of agency staff and also the sort of movement of staff, because obviously if there's a shortage, you kind of need agency staff. So what can we be thinking about recommendations for the second wave? And also if you've got any insight on how BAME staff in the care sector are being protected better, if at all.
Yeah, so we've been hearing this problem from lots of people. We spoke to somebody recently called Anne, who said that since the pandemic happened, she's now had lots of different staff. She used to have a couple of regular carers, but because of illness or infection, they weren't able to come, and that she was now having about 12 people a week coming into her home. At the beginning, she was saying that often professional carers weren't given PPE, and she was asking them if they could wash their hands and asking where their PPE was, and they were saying we have to buy it ourselves, we're not being given it. Now I hope that has significantly improved, but I think what is of course still a problem are people being tested and they could be going into sick, which I know many professional carers are really concerned about. So I think one thing is to maintain the testing for all care workers and make sure that they get what they need. The thing that I guess could be looked at for professional carers, whether they're agents or not, and whether they're in the, I should say, home care is also really important. I think care homes spoken about a lot, but there are so many people receiving domiciliary care in their own homes. They also need, those carers need the same. There are staff who are at particular risk, whether that's because they're Black, Asian or minority ethnic groups, or whether that's because they've got diabetes or another condition that would put them at more risk, that the companies that manage the care home, the professional carers or the local authorities put in place mechanisms where those people can only visit the same client, keep that regularity, rather than making lots of different homes all the same for them, but also isn't good for the person leaving.
Ruth?
I just wanted to make a quick point, I guess, about the scale of this. Just so, in March, around 25% of frontline care staff were unavailable to work at one point, and that was about 170% increase in sort of sick days would have been average. So, I mean, it was an enormous logistic challenge, and yes, absolutely. So the facet that we then had staff moving between different homes, and then, as Morgan has said, coming into people's own homes, has undoubtedly had a very significant impact, and it's absolutely something we need to be very conscious of moving forward. And it's also an area, I think, going back to that lack of knowledge and that lack of understanding at national level, that was never actually factored in, I think, to the way that people thought this might unfold around care homes and what might need to be done. So I think that's a really important lesson learned. The other thing that I would say is, and in terms of a recommendation, we know that there's a significant number of people who step back from receiving domiciliary care services during this period, including, in addition to those people that Morgan has already articulated, who have kind of seen their packages cut, reduced, or compromised in some capacity. And rebuilding the confidence of those people to receive domiciliary care into their home again is going to be absolutely paramount, because these people cannot continue, informal carers cannot continue indefinitely to provide the support that people need. It's putting a tremendous strain and pressure on informal carers and families, and of course is contributing to that picture of deterioration I laid out in the first instance. So looking at how we work with domiciliary care differently over the coming winter, to think about how we put in place, in inverted commas, bubbles, so that people can be assured of, so it's not, so in addition to those questions about testing and PPE, but actually how people can be assured of who they're receiving into their home, and that we can try and minimize those kind of contacts insofar as possible. That will take money and support for the sector in order to be able to look at doing things like that, but I think it'd be well worth it, because otherwise I don't see how we will rebuild the confidence of many of those individuals to restart receiving services that they really do urgently need.
Thank you. I wanted to move on to testing now, and more broadly, Lord Strasburger was going to kick us off, and we will cover testing on discharge as parts of our follow-ups as well.
Thank you, Chair. I've got two questions, one about testing and one about track and trace. To save time, I'll ask them together. First one is, how content are you with the way the testing service is now operating, particularly in care homes, and what, if anything, still needs to change? And the other question is, are you happy that the government has finally come around to locally run track and trace, and what more needs to be done to get track and trace running as well as we need it to?
So, Chris, I know you talk quite a lot about test and trace in your evidence from NHS Providers. Should we kick off with you?
Yeah, so I think as ever, across a whole load of things, we're clearly on a journey here. We'll be releasing a survey later on in this week, in fact on Friday, I think, which effectively is a survey of our members of how happy they were with the testing strategy up to now and also going forward. And I don't think it'll come as a great surprise when I say that they're not particularly happy and they're not particularly confident. I think, to be fair, particularly on NHS Test and Trace, our kind of sense was that should have been set up properly 3 months before it actually was. It's on a journey. I think and comes out in our survey actually, is that our members are more confident about what is now in place, but clearly there are a whole load of different things that need to be done. So if I just give you 4 or 5, the first is it's very clear we need to up the percentage of people who we are putting into the test and trace system. We need to up the percentages of people who are actually giving their contact details. We need to up the percentages of people who then actually, when contacted, isolate. In order to make that happen, second issue, we agree very strongly with those who are arguing that government financial support for those who find it difficult financially to isolate for the required 14 days. If you really want the isolation to happen, you're going to have to, boost that support. Thirdly, the government has said very clearly it wants to get to 500,000 tests by the end of October. It hasn't set out how it's going to achieve that. And that is fundamental for the testing of all health and care staff. And our kind of sense is that, the reason as to why you're not seeing promises that have been made about care staff being tested is the capacity, but it's not just the capacity. It isn't there, but it's not just the capacity. It's also the fact that you need the testing close enough to where the people who need to be tested are. Clearly, it helps if you can do postal tests, but actually, this, again, NHS Test and Trace has promised that you'll be no more than 30 minutes walk away from a testing centre by the end of October. Again, we need to see how that's going to work. I think the fourth issue, which again is something that people really haven't talked about, is when you really look at the places where there are concerns about local outbreaks, they do tend to have a particular demographic profile. They do tend to be areas that tend to be quite deprived. They tend to quite often kind of have particularly high percentages of Black and ethnic minority citizens. They also tend to be places of high population density. And one of the things that Test and Trace, if you talk to directors of public health, they absolutely want it to do is they want the Test and Trace service to reach more effectively into those communities, some of whom, to be frank, don't particularly want to interact with the state and are not used to interacting with the state. So there are a whole bunch of things that we kind of need to do in terms of building capacity, in terms of ensuring that we can get rapid test turnaround, ensuring that therefore when we get to winter, and this is the really important point to make, is when we get to winter, it is clinically very difficult to tell the difference between winter flu and COVID symptoms. And the key to doing that is to have sufficient testing capacity with at least next day turnaround in order for you to identify whether you are looking at a winter flu patient or whether you're looking at a COVID patient. So there is huge amounts of work to be done. I think, as I said, we're more confident about where we now are than we were certainly 4 or 5 months ago, but there's an awful lot that still needs to be done before we can be confident that we've got a fit for purpose, let alone world-class test and trace service in place for winter.
Thanks. I wonder if we could bring you in, Helen. I'd like to pick up on Lord Strasburger's question around testing availability in care homes at the moment. We know there's been a commitment for repeat testing. Can you just update us on what the status of that is on the ground, and particularly whether learning, to your knowledge, learning disability homes are now regularly accessing testing?
So we, as an organisation, we work with older people receiving care. So I wouldn't be able to specifically answer around care homes that are specifically for people with learning disabilities. But there was a unison survey of care workers in July, which may pick up on both of those types of settings, which found that 18% of staff hadn't been tested at all during the pandemic. And of those tested, only 46%, though 46% have been tested only once. So clearly there is still a problem with regular testing, which, as we know from lessons from elsewhere around the world and from the really strong message from the World Health Organization, that test is the route to managing this pandemic. There was a commitment from the government at the beginning of July, as you know, to test care home staff regularly. There was no mention of domiciliary care or other care settings like sheltered or supported housing. And we now know that that has been delayed until September due to some issues with rollouts. Care providers that we're in touch with tell us that testing recently has become more unreliable, and they've not had any news of the new test that's been developed, the rapid test, which would turn the results around more quickly.
Was there anything, Morgan or Ruth, you wanted to add on this point before we move on to testing on discharge from hospital?
Yeah, I can come in and then so we, the same as Residents Relatives Association, we don't own care homes or run them, but we do speak to people that manage care homes quite a lot, and many of the people that we support do live in care. From a few of the people we've spoken to who manage care homes, they've been saying that recently the testing service has been really challenging, that they've had swabs come back with no answer about whether the person's got it or not. Also swabs going missing or swabs not being available. So they're finding it really difficult, some care homes, to abide by the new guidance that they have to test staff and residents. Obviously they want to do it, but they're finding that the swabs aren't available and the tests aren't coming back. So that's one thing that I would flag is worth thinking about, making sure that care homes and those in domiciliary care and sheltered accommodation have the equipment they need to be able to abide by the guidance which they want to make sure that everybody stays safe.
I just add to that one of the issues that we've certainly encountered, in addition to those points that have been raised, is actually about sharing of test results as well. So care home residents or people receiving care in the community, they're being tested and those results are not being shared necessarily with their GP or with the clinical team that is supporting and looking after the residents within that care home. So, you know, some community geriatricians have described it to me as like getting blood from a stone in trying to get data across the different pillars and to actually understand what's going on in the care homes and for the residents in the area that they're supporting. And that actually is a real drag on them having a very effective clinical response and providing the right clinical support into care homes.
So just to be clear, Ruth, after people have had a test, where are the results going?
So my understanding is that it's a difficulty in that they are struggling to access, and Chris will correct me if I'm wrong, Pillar 2 testing results, that those are not being automatically shared with NHS teams working in localities, and certainly that the results of those tests are not being sent to the individual patient's GP. So looking at it from both angles, that there's a difficulty there in actually ensuring that partly just that residents or people who may be in need of clinical support as a result of that diagnosis are getting it, but then also for NHS multidisciplinary teams that are supporting a number of care homes in their area in order to really be understanding what's going on for those care homes and making sure that they're directing care appropriately.
Can I just check? Care homes are getting the results, are they?
So the issue, Madeira, affecting it's something that affects both the NHS and it affects care, is that effectively at the moment testing is happening in a number of different places, as I think you probably know. There are NHS laboratories, there are PHE laboratories, there are Pillar 2, which effectively is the Lighthouse Labs and the government contracted central testing operation, and then you've got what we call the flotilla of small ships, people like the Crick Institute, etc. Clearly, if you use an NHS lab and if you use a PHE lab, then the IT systems are pretty well connected, and effectively what happens is that results from there tend to flow direct into care records, NHS care records, and that tends not to be a problem in terms of NHS staff and care staff, because if they've got access to a single care record, being able to access that data. The problem is that because we've set up these different, for understandable reasons, we've set up these different sources of testing. What we certainly hear is that the reliability of the information from particularly Pillar 2, which is the Lighthouse Labs and the government central contracted tracing, the speed with which and the consistency those test results then get translated into NHS records and are therefore available via a single care record is patchy. It's not it should be, and that's the reason. It's because effectively previously all testing of this type was basically run through NHS labs, which effectively was set up to link to the care record.
Okay.
So people have described having to do that manually. Firstly having to, kind of attempt to get hold of the results, and then having to manually transcribe them across so that they can have that clear picture across their locality.
But the individual in the care home is getting the results, even if the NHS systems aren't talking. Is that what you're saying? I just want to nail down this point where the results are going. Yeah, okay.
Although that does raise another problem with the testing more broadly for older people around some things around access and digital access. So that's a slightly different issue. But you still need to have essentially an email address in order to receive test results, and obviously for a lot of older people that they don't have that, and that's proving a barrier for community testing as well.
I know Dan wanted to follow up on some questions on testing.
Yes, thank you, Manira. Clearly this is a difficult issue. I was specifically going to look at the issue of discharge from hospital, which is, and just a couple of quick questions on that. I mean, firstly, there is evidence from what we have seen and understand of what happened in Italy that keeping people in hospital, having people in hospital with coronavirus in the same place as other people who have not got coronavirus in itself can lead to cross-infection and a very real risk of increasing, mortality rates for those patients who are in hospital. And I just wondered, just to get a flavour of, perhaps from Chris, about what pressures the NHS faced and where the push came from in terms of encouraging rapid discharge from hospital of people who had at that time in March and April when we were at the peak of the first wave.
So this is a highly contested area, and I'm conscious that I'm giving evidence with 4 colleagues from social care. And to be frank, if I'm honest, I think we could have spent the whole 2 hours just on this issue because it is quite a complex issue. But just to remind you of the context, at the point when the discharge process happened in mid-March, the NHS and the government and the general population, I think, were very worried about what was going on in terms of Italy, where there was an overwhelm. So an instruction was given to the NHS to create the extra capacity. We did that in a number of different ways. I've already referred to creating the Nightingale hospitals, contracting private sector capacity, but we also agreed that we would speed up the discharge of medically fit patients. There was a good reason to do that, which is exactly what you were suggesting, which effectively is that what you don't want anyway, generally, is people who are medically fit in hospital, but particularly given that there is a potential infection risk. So what happened was there was a very clear instruction came from the NHS, from the NHS central leadership on the 15th of March to make those discharges. The detailed process was set out on March the 17th in a detailed note, which effectively said very clearly, could you please do this in an extremely collaborative way with both local authorities and local social care providers. What then happened is that there was a rapid discharge process of medically fit patients. The issue, given that we're talking about testing, as I'm sure you all know, is that at that point there was insufficient capacity in order to test the number those discharges. And if you remember, the guidance was very clear, which was it was acceptable for the NHS to discharge patients without a test, and the requirement to discharge with a test only arrived in mid-April. Now, the obvious question that we all would like the answer to is, did that seed coronavirus into care homes? Or to use Judy's formulation that she used right at the beginning, did that directly lead to excess care home deaths? And the answer is, we just don't know. The answer is you would need to go through an individual case note review exercise for each individual patient that was discharged to ensure to try to identify who then subsequently got coronavirus. For example, where did they get that coronavirus from, and can it be directly attributed back to the NHS? And the answer is that work has not been done in England. Interestingly, it has been done in Scotland. And as I understand it, the Scottish evidence shows clearly that actually there were very few, if any, cases where effectively patients discharged from hospitals actually it can be proved that they brought coronavirus into the care home. So for us, and I accept this is very much an NHS perspective, there has been a lot of misreporting and a lot of speculation that the absence of testing directly led to the level of mortality in care homes. And the reasons why I wanted to slightly jump in earlier, Manira, is that effectively, if you look at the evidence, so for example, the ONS evidence, what the Office for National Statistics say is when looking at care home mortality, actually the most statistically significant link is to issues like staff infection rates. It's, for example, the reliance of care homes, some care homes, on higher numbers of agency staff and carers. There is a definite link between care home staff care homes who employ staff who work across multiple sites. A PHE study believes it's found a direct link between the size of a care home and the greater rate of infection. So that appears to argue that there is a tripling in the rate of infection with every extra 20 beds. There's a study from the University of East Anglia that basically says that outbreaks are more likely in places that employ higher numbers of support staff, such as cooks and cleaners. And there's even some evidence from the ONS that actually when staff receive sick pay, rates are lower. So I thought we had a really good conversation earlier with both Judy and Helen, where they were talking about the kind of reasons as to why there has been coronavirus outbreaks, infection rates in care homes. I think this idea that somehow right at the beginning, this discharge process effectively seeded vast amounts of coronavirus in care homes is yet to be proved. And Dan, you probably know, we have been, and I personally have been very vociferous on this. And the reason is because our members are absolutely clear that they knew there was a risk if they discharge patients without a test. And they knew they had to manage that risk very carefully because they spend their whole time working with care homes trying to ensure that they can provide the best quality of care. And so what our members say to us is they were working under a very difficult constraint of not being able to access testing, but actually they very carefully managed that risk to try to ensure that they protected care homes. And the bit that really incenses them and makes them very angry is the suggestion that to protect themselves, they very deliberately transferred known and suspected COVID patients on a systematic basis to care homes. And that is why we have been very, very strong to say that actually that we've seen no evidence of that. Our members find it really quite distressing when the suggestion that that's what they did is consistently repeated. To be frank, what we need to do is to do the detailed case note review exercise and really go through it on a kind of consistent basis. That will take a lot of time. It's something that our members would like to see done, but of course they can't do it by themselves because they actually need to do the kind of case note review exercise of the care home record and link the two up. But the bit I really would say incredibly clearly is, could we please stop saying that the NHS deliberately seeded and the NHS seeded coronavirus through the discharge process by not having patients tested? Because as far as we're concerned, and as our staff are concerned and our leaders are concerned, there is not the evidence there to justify that claim.
Yeah. Thank you, Chris. I just got one follow-up for you very quickly, but I think it's important to bring in everyone else perhaps on this particular question initially of discharge from hospitals. I don't know who would like to address that from our other witnesses.
Sorry, I didn't hear the question very well.
No, sorry, I was just saying that I have one quick follow-up specifically to Chris, which is sort of follow-on from what he was talking about. But I think actually just generally in terms of the challenges that there were in the system with rapid discharge of patients from hospital, I think it would be useful to hear from everybody else what your perspectives are on that.
Well, clearly, as Chris says, the capacity wasn't there. I mean, hospitals didn't have any alternative if they were to send people back to care homes or back to their own homes. At the point at which Chris the peak of the virus, people were having to be discharged without being tested because there wasn't the capacity. Some hospitals were testing people who were leaving and were found to have the virus, and they did go back into care homes, and the extent of transmission would depend on the extent of infection control nursing, barrier nursing, and the availability of PPE and so on. But to go back to the government statement on testing, by 500,000 by the end of October, we're talking about almost 2 million social care staff in both the domiciliary and care home sector. And testing isn't a once for all procedure. We know that you can be COVID-free on Sunday, but have symptoms 4 days later. So it's got to be a reiterative system. So to have a target like 500,000 by the end of October doesn't actually cut it. It's got to be a reiterative system where staff, and as somebody else pointed out, the ancillary staff in care homes, people who are absolutely essential, like the cooks and the cleaners and the handymen, must also be tested on a regular basis. Otherwise, we're just moving it.
I mean, one of the things, directions I'd have is I'm just looking at the questions as well that Baroness Altman has typed into the chat, and I just want to reflect on the second one, because I think that is a very important question, and it's one that we perhaps haven't considered enough in this debate, where it's been very much, as I said, the focus on who left hospital when and why. And I think that this is really important. I do think that there were across in localities and also in some localities and also at national level, a naivety, a lack of understanding about what it would be possible for care homes to do, for a couple of reasons. I think, and we've seen this in some of the guidance to care homes around, for example, infection control. They're not hospitals, they're people's homes. And that creates a different, and so therefore you need to approach infection control in those environments in a different way, because the sorts of things that you might do in a hospital environment are not necessarily possible in people's own homes. Where they will have soft furnishings, for example, because it's their home. So some of that has been reflected in some of the guidance, but also again, and this question about care homes not having medically staff on site, I think sometimes that's overlooked and poorly understood. Large numbers of care homes are in fact residential care homes, so they are staffed entirely by untrained clinical staff. They have no trained clinical staff on site. And even in nursing homes, actually, it's quite a small number of nurses who will be providing support to a whole nursing home. The majority of support in that context will be being provided, again, by non-clinically trained care staff. So I think we have to be, and it's really important we do get this right, because as we head into winter, we need to be able to ensure that we can safeguard the health of care home residents. That has to be absolutely paramount in our thinking. So how do we ensure that care homes are supported to manage infection control? And of course, there will be patients who are discharged from hospital, because there is no value, as Chris has said, in keeping people who are medically fit to be discharged in a hospital bed, in terms of their own health, let alone the broader implications of that for the NHS. But we have to be able to ensure that however infection arrives in a care home, that people are able to manage it, and they're able to manage it safely, and they have the support, and they actually have they have guidance which is practical, it's implementable, it absolutely understands the context in which they're working, and understands the skill sets of the people who are available to implement it. Because unless we get on top of that, I fear that whatever way a virus finds its way into another care home come winter, we'll see the similar kind of tragedies unfold.
And Munira, I think there's a really important thing for people to understand is there is a vast difference between national guidance and what happens on the ground. And certainly when we were executives and clinicians, what they were basically saying to us is, look, we know these care homes, we work with them every day. We're quite often pulling patients in, we're quite often advising on the phone, we're quite often discharging. This is a very regular process for us. We know exactly who is likely to be at most risk. We know exactly where we need to be particularly careful, given we have this limited testing capacity. So actually, this particular resident, we're not comfortable about kind of sending them back. And yes, Dan, you're right. There was a huge pressure to make this happen at speed. But the sort of simplistic view that somehow everybody just very quickly, willy-nilly, discharged everybody, completely uniform way without thinking about, you know, the destination to which they were going. It's just not true. And I think the politicians who were making those decisions feel very strongly that actually that is denigrating the quality of thought they put into how this process worked.
No,
thanks, Chris. I'm keen because we're short of time, and I know Barbara still needs to come back on some questions on shielding. Can I just ask one last question on discharge? Just wanted to get clarification, maybe from Helen. You might be best placed to answer this. I mean, are you confident now that there is this routine testing on discharge, and that we're prepared for that in the second wave? And actually, when there are people coming in from the community, are they being tested before they're being admitted into care homes?
So from my understanding, the testing, the route from NHS into care, the testing is more likely to be in place in the NHS. I've mentioned problems with testing people who are, you know, regular testing within care homes. Sorry, was there a second part to your question?
It was brought to my attention that people going into care homes from the community can't access testing unless they've got symptoms, which seems absurd to me. So is that also your experience?
Well, again, it goes back to sort of the management of that virus. So when people are coming from a different setting, whether that's hospital or the community or from elsewhere, the guidance now is that people are asked to self-isolate for 14 days. So that if they do have the virus, even if they're asymptomatic, that, you know, that isn't spread within the first 14 days of them arriving.
Okay. I just wanted to move on to Barbara on shielding because I'm conscious of time now.
Okay, and perhaps we can expand this more broadly to moving on in the last part of the meeting to recommendations to help with the second wave, because we had some interesting comments before about shielding. So if I just go back to that, question is really around how might the government guidance have been clearer, because I think we've heard of problems with it, particularly for those who didn't need to be shielded. And in terms of withdrawal of shielding, which happened very recently, obviously at the start of August, was the way that was done appropriate? How did people respond to it? So, you know, one, how could the guidance have been clearer? And, you know, secondly, in terms of its removal, could that have been done in a better way too? And I suppose thinking of these things, not just in terms of what went wrong, but what changes could be made for the future if shielding is needed again for the second wave. And obviously, Ruth and Morgan, you've both talked about that.
I'll kick us off but so I think one of the biggest issues that we encountered with this, I think partly, just to be really clear, I think probably some of those issues that Morgan spoke about in the first instance, that just if we all cast our mind back to what feels like an absolute lifetime ago now, to early March, we had an announcement from government that said one weekend that said people over the age of 70 would be asked to self-isolate, to shield, to stay at home, you know, to practice social distancing measures, you know, however you want to frame it. That then quite quickly moved to saying, actually, no, we were going to have a nationwide lockdown, which would of course impose social distancing on all age groups. But then we were also going to identify these additional groups of the clinically vulnerable and the clinically extremely vulnerable. So I think for older people who had heard that very initial message about all people over the age of 70 being asked to isolate, to practice social distancing, that then carried through. And then these subsequent messages about, oh, well, this group and that group, and oh, the over 70s are this unless you're a that. You know, it created quite a confused picture, which I think, as Morgan said, led to a perspective, not just amongst older people, but actually amongst a lot of their families and friends and relatives, that they ought to be shielding. So I think we have to, I think we need, if we head into a second wave, and of course we're aware that there is work going on through the CMO's office to look at refining that shielding picture now that we know more, to create a different risk tool, to think about who might be being asked to shield in future. That will be possibly a slightly different group of people. So that gives us an opportunity to think much more clearly about how we communicate with those individuals and make sure that they absolutely understand what the risk is and what's being asked of them. The second point that I would make is, One of the challenges that we found at Age UK is that, of course, we received, a tremendous volume. Our calls to our advice line, our visits to our websites, all of these sorts of things went skyrocketed. And people had some very particular questions, because actually government had set very high level guidance about what people needed to do in order to safeguard themselves, but people's lives are more complicated than that. And they had all sorts of questions. Is it, can my daughter still come over and help me with this? Can my cleaner come in? Because actually I can't clean my house. I can't change the bed linens by myself. Is this okay? Is that okay? What's the risk of packaging? People had so many questions, and they were really trying very hard to safeguard themselves and their loved ones, particularly for people who perhaps hadn't been advised to shield, but they were very aware that they themselves or somebody they loved were in a very fragile state of health. And where we, I think, struggled is what would have been particularly helpful to us as Age UK in answering more of those questions is to have much, much better access to the evidence base, to the data, to have a much, much more open and transparent and shared understanding. So again, if people recall, a lot of the evidence that these decisions were being based on was not publicly available. It was not being made available to us, so that we ourselves could interpret that and try and provide the best information that we could to older people and their families around some, all the different permutations of what was going on for them. So again, going into a second wave, much, much more transparency over the data, much better access to the evidence, so that we can really do our job, which is to support older people to understand what this means to them.
Thank you.
I'm keen quickly to hear from you, Morgan, before we wrap up.
Sure. So we did some polling actually earlier, like during lockdown, where we asked people whether they thought that shielding was the guidance for everybody over 70, even if you were healthy and didn't have any underlying health conditions. And we had a really high percentage of people say that they did think that was the guidance. So that told us that the calls we were getting on the helpline were illustrative of the fact that many people over 70 did believe they should be completely shielding, which is obviously really concerning because of the impact on their life and what that would entail. A few things that I would say that were really problematic specifically about the guidance. One is that, as I said earlier, the clarity of what was meant by things like take particular care. I don't think any of us would understand what that means. And keep asking for clarity. And I think if you're going to tell a group of people, whether you've given them the decent evidence or not, if you're going to say, we think you're at more risk, they need to understand how they can mitigate that risk. And I don't think that was happening. The other thing that I mentioned earlier was around changes to guidance. So a specific example is almost on the same day, there was a change where all shielders were told they could now go outside once a day. And at almost the same time, other people were told you can meet up to 6 people outside. Now, I heard from people shielding who thought they could meet 6 people outside and were suddenly going to the park and meeting lots of relatives because it hadn't been made clear enough that there was different social distancing guidelines for the different groups. And I think the changes happening simultaneously for different groups was also really, really confusing. In terms of what we as an organisation would want to see going forward, if we enter a situation again where people do need to shield, or where we think other groups are more vulnerable, but don't need to go as far as shielding, but they are more vulnerable to the virus, we just want clear communication. At the moment, so much is online. Lots of people over 65 are online and lots of people over 70, but many aren't. So there needs to be clear communication on multiple channels. And we think that there needs to be targeted communication to groups in communities, like through local community groups, for example, who can get the messages out. And we appreciate that's difficult with the speed the changes are happening, but that's really important if we go into a second phase.
Yeah, thanks. And thanks, Maria. Just to say to Morgan, you mentioned earlier about different levels of support from different local authorities. We're not going to be able to have time to go into that, but perhaps if you could let the committee know any more about that, because I think that's an interesting point. Thanks, Maria.
Barbara, you asked about how the guidance could be improved in future. People shielding were getting 4-page letters, densely written, hard to understand. That is just not acceptable, even if you have the energy to read through it. My partner was shielded, and he couldn't. I mean, he's what I would call relatively well educated and motivated to read things. He just gave up after page 2 in despair. So I really think, and also it's discriminatory, this thing about over 70s. I was talking to someone from the RCN who has a team of nurses, all of whom are over 70. And they were all saying, well, are we not allowed to work? They were all doing important work. We've got to stop discriminating against people simply on an age basis. It's not sensible and there's no evidence.
Thank you.
There's one more thing that hasn't been said, Munira, which I think is important, is that effectively, I get the point, Morgan's right about speed, but there are some of these decisions that, to be frank, that they didn't need to be made in quite the speed in which they did, particularly the later ones. And the real problem was that there was no advice given to those who advise patients. So medical professionals and care professionals were put in an impossible position where they were being rung up by people who'd seen something on the news and had only just received the advice themselves. So the other thing I would say is just be careful and think through, government, about how you ensure that those to whom people who are affected will turn straight away, including the organisations on in this session, but also medical professionals and care professionals have got the information they need to provide the right quality of advice. And it's not rocket science. And my argument to you would be that actually most of the decisions that are going to be made now, probably actually you will have the time to do that.
Okay, well, thank you. I'm conscious we're out of time, and whilst if people are okay for me to trespass on your time for a couple of minutes more, just as a sort of final thought, I'd just like to go around the panel very, very briefly, like one word or one sentence. Ahead of a second wave, from your perspective, what is the most urgent thing that needs to be rectified? I just want you to pick out one thing, please, from your perspective. I'll start with you, Morgan.
So for me, ahead of a second wave, maybe just coming back to what I said at the beginning about bereavement support and mental health support, and they're going to be needed, whether we have a second wave, they're needed now, they're going to be more needed if we go into a second wave. And I'm sure others will cover the protections that, of course, we need for care homes and for those who are told to shield on medical grounds. But I think making sure that the support is there so people feel they can get back to life and feel confident doing so is really important.
Ruth, one thing from you, from Age UK, please.
I think overall, I would say that it's really important that any decisions being taken here on out are absolutely informed by people who have really good expertise in the care of older people. And that's not been the case to date. And I think we have seen some of the ramifications of that.
Thank you. Judy or Helen from the Relatives and Residents Association, one of you.
Shall I rush in then, Helen? I think that we feel very strongly about the lack of oversight of vulnerable people in care homes. They haven't all got relatives, and a significant proportion, at something between 10 and 20%, have no kith or kin. So the withdrawal of any inspection, any oversight, any outside, monitoring really did do what the other APPG said about throwing older people to the wolves. We can't just leave people unprotected.
And from your perspective, Chris, finally.
So it's not a silver bullet, but we absolutely have to develop at pace a fit for purpose testing regime. We're sort of getting there, but it's got to be speeded up and it's got to be in place by winter. And if it's not, that really is a big problem.
Thank you. Thanks very much. Well, thank you all for your time. I hope you haven't all melted. I'm certainly in the process of melting. Yeah, thank you to all of you who've given up your time and expertise to give us evidence today, and also to all my fellow colleagues on the call, parliamentarians who've been asking questions. There's a huge amount for us to go away and digest and think about, and I know a number of us are keen to dig further into some of the issues that have come out today. So we will be following up. There's a lot of big complex issues that we've touched on today. So thank you again.
Okay. Thank you.